Hello everybody, welcome and thank you for joining us for tonight's webinar. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues with us today. My name is Jan Sadler. I manage the Practice Support and Development team here at Central and Eastern Sydney Primary Health Network. My colleagues and Practice Support Liaison Officers are with us tonight to help out with questions and answers. So introducing Fleur, Niven and Evelina Koza. We have a team of Practice Support Liaison Officers to help you with all things general practice, including accreditation, quality improvement and activities that might go with that, orientating your new nurses and GP registrars if you have any, the practice incentive programs and lots more. We also have our other wonderful teams at the PHN to help you with digital health training opportunities and immunisation, and our population health and mental health teams have great training opportunities for you and your staff, including intellectual disability, domestic family violence, mental health programs. So if you would like to be linked in with any of our other programs or teams, please don't hesitate to let us know. See our email at the end of the presentation. I would like to introduce our presenter for tonight. Please welcome Michelle Horswood. Michelle is a practice manager and nursing consultant. Michelle has been a nurse for 42 years, working in general practice and now for 20 years. Michelle has qualifications in both nursing and management. Michelle loves primary care nursing and firmly believes that our skilled primary care nurses underpin the future of caring, efficient and cost-effective general practice. And I'm sure we all agree with that. Thank you, Michelle. Happy for you to take it away. And now we can get started.
Okay, well, thank you everybody for joining us tonight. I'm sure you've all had busy days and, I feel very valued to think that you've come to listen to what we're going to talk about tonight at the end of your busy day. So while I was waiting for the presentation to start, I was thinking to myself, well, we're going to talk a lot about chronic disease management and the how-to of that. But I was just pondering on some outcomes that I can absolutely guarantee you will occur if your practice can implement a sound chronic disease management program. And the things that I jotted down here are that we improve our patient outcomes, undoubtedly. We decrease the incidence of our patients going unexpectedly to hospital. We reduce the need for episodic care. So our GPs start to see our patients in a planned routine basis. So things that would previously pop up after long periods of not seeing the GP don't occur anymore. And we also improve our practice income because our GPs are actually being paid for the services that they're offering to their patients. In many years ago, when I first started working in health, if a person had diabetes or heart disease, they would see their GP and their GP would refer them to a general physician that would look after their complex care needs. And of course, we don't have that anymore. Our GPs are expected to look after patients in the primary care setting, and they do that very well. But a planned, structured model of care seems to work much better with those patients with complex care needs, and that's what we're going to talk about establishing tonight. And we've got lots to get through, so I'm sorry if I'll try not to race ahead too much. And if you do have any questions, hopefully they will be answered throughout the presentation, but if not, we'll try and get to those at the end, as Jan said. So our first learning objective is to understand what defines a chronic disease for the purpose of chronic disease management planning. So in other words, what does the Department of Health tell us equates to a chronic disease for the purposes of caring for people in general practice and also for billing Medicare. We also hope to understand the Medicare requirements for a GP management plan and a team care arrangement, and I'll spend quite a bit of time talking about that. We also hope to be aware of the processes involved in developing the care plans well and explore some possible clinical workflow ideas for your individual practice. And lastly, to know what billing items can be claimed and the time periods for these. And particularly when you first start doing chronic disease management planning, the billing items are just a minefield. It's very confusing and hard to work out initially. So we'll spend a little bit of time talking about that. Okay, so to start with, our first objective is to understand what defines a chronic disease for the purpose of chronic disease management planning. The idea behind chronic disease management is to manage the healthcare of people with chronic and terminal medical conditions who require a structured approach to care. A chronic medical condition, according to Medicare, is something that has lasted for longer than 6 months or is expected to last for longer than 6 months. And this can also include a terminal illness. So there's no list of eligible conditions that's been provided for us. So we can actually, think fairly laterally about what patients might be eligible for this type of care planning. And I think that's where, our nurses can be very valuable in looking at patients and looking at what their medical problems are and how we can best establish some sort of structure to their care. So our next objective is to understand the Medicare requirements of a GP management plan and a team care arrangement. And I'll also talk about the review of each of those plans. First of all, the GP management plan, which is item 721. And so here we'll start with the numerous item numbers that we utilise for chronic disease management planning. But the main sale is the item 721, which is our initial GP management plan. And the first thing that we must do is ensure patient eligibility. So we go back to the definition of what is a chronic disease and has the person had this condition for more than 6 months, or are they expected to have it for more than 6 months? So that can be things like osteoarthritis, blood pressure, high cholesterol. It doesn't have to be some serious terminal illness or anything. It can be something that just would benefit from a structured approach to care. And we know from our statistics, which the PHN are often the ones who collect this sort of de-identified data, we know that in our average everyday general practice, possibly 25% of our patients would benefit from a GP management plan. And that's also very, very dependent on the demographic. So you may have a practice like the practice that I manage in the city that has, our the bulk of our patients are between 30 and 50. So that the percentage of people who are eligible for a GP management plan may be a little bit less than average. But if you look at the other practice that I work out at Bronte, where we're looking at caring for families and generations of families, the percentage is probably a little bit higher. So it does definitely depend on the demographic of your practice. And the other important thing is that we can't bill an item 721 for someone that's an inpatient of a hospital or care facility. So this is not an item that we would be billing for your nursing home patients, for example. The next thing is that you need to develop a plan. So the nurse can collect the information for that. So you can do that by reviewing the file and talking to the patient, which we'll go through in a little bit more detail later. But most importantly, the GP must see the patient in order to bill this item number. You need to ascertain the patient consent. You need to talk to the patient about goals. And one thing that I would say is that these do need to be patient-centered, most importantly. So if you have a patient with diabetes, for example, and as the registered nurse seeing them, you think that you'd really love their HbA1c to be 7 and under. But for this particular patient, that's just insurmountable and much more realistic if they had a goal of having their HbA1c at 7.5. And as nurses, we need to listen to that. And it might not be a gold standard outcome that we want to see, but we must always remember to make our goals patient-centered. We need to identify the treatments and services and tasks that need to occur in order to achieve the goals. And we also need to establish a review, because every item 721 under the Medicare agreement is that it should be reviewed at least once during its life. So the things that you document, you record consent, you record the patient's needs, their goals, and the patient actions, as well as the actions of the healthcare team. You set a review date, and you must always also offer a copy to the patient. If the patient says they don't want a copy, you can just document that they've declined to have a copy. One thing that I've done with GP management plans in the past as well is, if the patient doesn't want a copy, I upload it to their My Health record as an event summary. So if they were to go somewhere where someone was able to access their My Health record, like the local hospital, they would be able to see that GP management plan as an event summary. Unfortunately, you can't upload it as a patient health summary. My Health record doesn't have the facility to do that, but you can copy it and upload it as an event summary. So to claim your item 721 on the day, all elements must be completed. You can't be halfway through it and the patient's going and you think, well, I'll bill that 721 and I'll come back and finish it later. Everything must be completed, must have been a GP attendance, and it's a serious amount of money that we're getting paid to do this. So item 721's worth $152.50. And there is another item that can be billed with your item 721, which is a 10997. And that's a nurse item number for participating in developing or looking after somebody with complex care needs. And the beauty of it, doesn't seem like a lot, $12.70. It can be claimed 5 times a year, but most often the patients that we're doing GP management plans are also eligible for the bulk billing incentive payment. So if you bill the 10997, you also get the incentive payment. So depending on your demographic, whether you're in a city, rural, etc., it works out to roughly $20. Again, doesn't sound like a lot, but it adds up over time. And particularly in your practice, if you have nurses doing care plans every day and they're seeing a number of patients each day, that the billing from that item number does add up. The interval for a 721, according to Medicare, is every 2 years, with the minimum being 1 year. You can also do it earlier than that if something dramatically changed for your patient. So if you had a patient who had hypertension and high cholesterol, for example, and then they had a myocardial infarction a couple of months later, and they already had an existing care plan, that would justify you being able to do a new care plan for that patient. And you just have to annotate that in your Medicare billing, that there's exceptional circumstances, that the patient's care has changed quite dramatically, and you're able to bill that within the minimum interval. And again, as I said before, you must review your care plan at least once in the life of your plan. Okay, so the next item that we're going to talk about is the team care arrangement, which is item 723. And you will get used to these numbers if they're alien to you to start with. Once you start using them all the time, you do get used to them. So for a team care arrangement, it's a document that accompanies the GP management plan. And the purpose of the TCA is to coordinate a team that's involved in the patient's care. And I want, a lot of people think that the only purpose of doing a team care arrangement is to provide an EPC form so that the patient can get some subsidised allied health appointments. I want you to move away from thinking that, because it's really about involving a team in the patient's care and communicating with that care team, whether they be allied health service providers or not. And that's the importance of this particular document. Again, the patient must have a chronic or terminal condition. They must have complex care needs, and they must have a care team which involves the GP and at least 2 other clinical providers. Now, again, there is a list of these, which is quite long. It can be the pharmacist, it can be the optometrist, it can be the person's dentist. So long as you're communicating with that particular service provider, you're providing them with your team care arrangement information, they can then be part of this team care arrangement and allow you to develop this document and bill the item number. And again, it's not for inpatients of healthcare facilities. So when you develop the TCA, the nurse may collect the information, but again, the GP must see the patient. And usually routinely, the TCA is done at the same time as the GP management plan. There are occasions when that varies, but it really helps for your billing and your review cycles if the person's eligible that you do it at the same time. An example of when it might be done separately is if you have a patient who has a GP management plan and they have minimal healthcare providers, and then something happens to them and they end up with additional healthcare providers. They want to see a physio or another allied health provider, and you then go on to develop the team care arrangement, and the billing cycle is different to the GP management plan. Sometimes it gets a bit tricky with Medicare, but annotating your Medicare claims and things can really help that happen smoothly. And there are occasions when it certainly happens like that. So when you're developing your TCA or team care arrangement, you need to ascertain that you have consent. You need to look at the treatment and service goals and remember that they need to be patient-centred. You need 2 providers other than the GP, and again, be creative about who they can be. And I would also highly recommend always recording who the patient's pharmacist is and who their dentist are, whether that's just for the GP management plan or whether it's for the team care arrangement as well. It can be very valuable information. You need to have the patient's agreement and consent for information sharing with the team, and you need to obtain your collaborating providers agreement. And in a minute, I'll talk a little bit more about the ways that we can do that. And you need to consult with the collaborating providers and get feedback from them. And again, we need to review these documents within their lifetime. So for your documentation for a TCA, you need to record your consent. You need to somehow put together the goals, the collaborating providers, the treatments, the services, and the patient actions. You should establish a review date. You send copies to your collaborating providers and also, again, offer the patient a copy. And before you claim the item 723, you must have completed all of the elements. You can't be halfway through it. You must have GP attendance to be able to bill the item number. When you do bill item 723, it's $120. So if $120.85. So if you imagine combining the GP management plan and a team care arrangement, you're looking at an appointment that will give you about $300 if you add in the incentive item numbers as well. And you can also bill the item 109.97, but you can't bill that twice. If you're billing an item 721 and 723 together, you can only bill one nurse item number. And again, the nurse item number will attract a bulk billing incentive payment as well. The lifespan of a team care arrangement is 2 years, minimum yearly. I would recommend to you in your practices to do new item 721s and 723s on an annual basis. And I would also recommend to review them 3 to 4 monthly. And what I usually say to patients is that you have a chronic illness, we're wanting to develop a plan of care for you, but all we're asking is that you come to see your GP 3 to 4 times a year for the purpose of looking after your chronic disease or your complex care needs. And when you think of it like that, the patients seem to be a lot happier to go along and do it that way. And again, you must review the TCA at least once. This is an example of what I was saying about ascertaining the collaborating providers agreement. So one way of doing it is to actually formalize a letter that you can put into your patient management software and pre-populate and generate for each of your patients that you're doing a team care arrangement for. And this letter you can send off with a copy of the GP management plan and the team care arrangement to the provider and request them to sign it and send it back to you. And also ask them if they're happy with your plan of care and if they'd like to change anything, that can be quite valuable as well. You can get verbal agreement from the collaborating providers. So if on the day, for example, you do get to know your regular collaborating providers. So if you have a diabetes educator that you regularly liaise with, you can give them a call and say, look, you've got this patient that you've established a team care arrangement for. Would they agree to participate? If they say yes, you can actually document that in the notes. You can say that the care team, including X, Y, and Z, have agreed to participate in this team care arrangement. And you can get the written agreement subsequent to that and still go ahead and bill your item 723 on the day, so long as you have got that agreement to participate and you have documented it in the notes. The other thing, or the other important document that you need to generate for your patients who have a team care arrangement, if they are wanting to see an allied health provider and they are wanting to claim the Medicare rebate from the allied health provider, which is they are eligible for if they have a GP management plan and team care arrangement, you need to do this particular document called an enhanced primary care referral. And you need to detail the GP and the provider that you're sending the patient to. This all gets sent off as part of your team care arrangement, and the patient can claim 5 subsidised allied health appointments for every calendar year. And what this means to you, it doesn't matter whether you do your GP management plan and TCA in March, April, or December. At the beginning of every calendar year, the patient requires a new EPC referral form. And if you're doing regular reviews of your care plan, it's usually fairly easy to keep up with this. And the patients usually come and tell you that their podiatrist or their physio has told them that they need a new referral in order to continue providing the care. When you do a new EPC referral form, it's an ideal time to also do a review of your care plan and your TCA. So please think of that in your programming. So if you had a patient, for example, who had a new GP management plan and team care arrangement in November, and they're wanting to see a physio, they actually have 5 appointments available to them until the end of December, and then in January it starts again. So it's good to have that in mind when you're developing these documents. And you might like to pop a reminder in your patient management software as well when these new EPC referrals are due. Excuse me. So now I'll talk about reviewing our GP management plans and team care arrangements. And this is item 732. And it's the same item number whether you review a care plan or TCA. If you review both, then you bill the item number twice. So you need to ensure that your patient's eligible. So they must have a GP management plan already in place. You can't review something that isn't there in the first place. You need to develop the plan. The nurse may collect the information, but again, the GP must see the patient. You need to ascertain consent, and you need to review all matters that are in the care plan, and you need to document those. Again, in your documentation, record consent, make your amendments, set your new review date, which I would recommend to be in 3 or 4 months' time. If the person also has a TCA, you copy in the collaborating providers, so you continue that line of communication with them, and you offer the patient a copy. So when you're claiming your item 732, all elements must be completed. The GP must have attended. The item 732 is worth $76.15. You can also add in your nurse attendance item number, the 10997. You can't review a care plan within 3 months of doing a new GP management plan or new item 721, and you can't complete a review within 3 months of a previous review. So there's a 3-month cycle there. You can claim your item 732 on the same day as a new TCA or item 723 or review of that team care arrangement. The recommended frequency by Medicare is 6 monthly, with the minimum being 3 monthly. And you must always annotate your Medicare claim to say what you've done. And again, I'd highly recommend that you get your patients into this review cycle. If you don't have structure, it'll fall over. You've got to maintain this structure, and that helps you fill your clinics as well, and keeps your role in caring for the patient, keeps it going. Hopefully that's clear, and we can talk about any questions related to that if you have them at the end. So the next review is a review of the team care arrangement. And again, that attracts the same item number. So don't get confused with that. The item numbers used to be different, but a number of years ago, they changed it so that the same item number gets billed, but you can bill it twice. So you're looking at, if you review both a GP management plan and a team care arrangement, you're looking at about $170, $180 if you add in your incentive items. So it's definitely a worthwhile thing to do. Need to ensure your patient's eligible. So they must already have a GP management plan and TCA in place. Again, the nurse can collect the information, but the GP must see the patient. You need to ascertain consent, and you also need to consult with your collaborating providers to review all matters in the team care arrangement. For your documentation, you must record consent. You must make any amendments that you need to, set a new review date, and then send copies of all of the relevant information to your collaborating providers and a copy to the patient. So before you claim your item 732, you must make sure that you've completed all items to claim. Again, you must have GP attendance. The item 732, $76.15, can be coupled in with another item 732. You can add in the 10997, but only add in one of those for if you do the review of both things. And you can't claim it within 3 months of your original team care arrangement or item 723. And it can be claimed on the same day as a GP management plan, 721, or review of that management plan, which is a 732. Medicare recommended frequency is 6 monthly with a minimum of 3 months. I would recommend that you do the 3 to 4 months, and that you always annotate your Medicare item in the service text so that it's quite clear what you've done and what you're claiming. So I hope that that was all as clear as I possibly can make it. I know it can be quite confusing, but hopefully with the next things that we're going to talk about, you might develop a little bit more clarity around that. So our third objective is to be aware of the processes involved in developing the plans well, and explore some possible clinical workflows for your individual practice. So this is when we get down to the, well, okay, that's what they are. How do we do it? So this is some, and again, this is some ideas that I have as a result of doing care planning and looking after patients with complex care needs over many years. And again, without structure, you have something that's ad hoc and doesn't live a long, fruitful life. It tends to die. So please try and maintain an established structure. Work with your GPs to look at, well, how our practice works and how we can do it. But the very, very first thing we need to do is to think, well, how are we going to identify our patients that are eligible for a GP management plan? Number of different ways. I'm very much a lover of the appointment screen, and nurses that have worked with me will know that I get them to look at the appointment screen for their GPs for the following week and look at building a care planning list from that. And this is just when you get started. And what you'll find, once you've got an established care planning clinic where your patients are rotating through and they're coming regularly, you're only looking at your appointment screen to recruit new patients. Whereas when you first start off, you're looking at a startup. So you're looking at trying to find ones that don't already have a care plan. And this can be done very quickly by a quick assessment of the appointments that are booked in, just by quickly viewing the patient's records to see if they do have a chronic disease and if they would be eligible for a care plan. There's also infometrics that you can use, such as Cubico, and I have used Cubico for the purpose of identifying patients who are eligible for chronic disease management plans. Very clever program. It looks at billing as well as clinical data, and develops a list of suggestions for you, which it certainly saves a lot of time. If you the alternative is to look at the appointment screen and the patient's records manually. So it's certainly a huge time saver. The other way of identifying patients is what I would describe as opportunistic. So you can have patients self-identifying. So you can have signs in the waiting room that tell patients that you've got this chronic disease, or coordinated care program. The term chronic disease conjures up some things that sometimes is not favourable for patients. So try and think of a creative way of describing what you're going to be offering in your practice. And the patients may then say to you, when you're giving them their flu vaccine or taking their blood pressure, oh, I saw that sign in the waiting room. Would I be eligible for that? So they can self-identify. The GP may identify them because they know their patients, and when they see them pop up, coming up for an appointment, they may alert you that this person is eligible for a GP management plan. Or you may identify them in your own appointments when you're seeing patients for dressings, immunisations, etc., that they are eligible for a GP management plan and or team care arrangement. The other way of identifying patients, and I'm certainly not a fan of developing big lists of looking through software and developing big lists of patients, or even small lists of patients. I think that your search will be much more fruitful if you look at your captive audience, which is people that are already booked in for an appointment. lists can be valuable at some level, but again, I think that you will find enough patients to start a program just by looking at your patients that are already booked in. So that's identifying the patient, big, important first step. The next thing you need to do is to ascertain patient consent to having a care plan. You then open their file, and this is a really important step that I'll talk a little bit more about later, is that you have an opportunity to cleanse their data, tidy up the file, take out the things that are no longer relevant, move active problems to inactive problems, check medication lists, etc. And again, I'll give you a bit of a guide for doing that. And I've also provided that to the PHN if you're wanting to access that information also. And you need to look at information gathering before you even start to build the care plan, which I'll talk about again a little bit more later. So then you start to construct your GP management plan with the information that you've got available to you. And this is before you even see the patient. So I'd highly recommend having protected time to prepare the care plans. There's nothing worse than sitting with a patient for an hour and all you're doing is looking at the screen and you're typing up information while they're sitting there. There's so much work that you can do before you see the patient so that you can have it all prepared and ready pretty much with just a few adjustments when you actually speak to them. When you see the patient, you can cross-check the information and the data that you've collected. And as I said, remember to add those other important providers like the dentist, optometrist, pharmacist, etc. You need to explain, during the consult, you need to explain the, sorry, I just got to cross this out. You need to explain the process to the patient. Good opportunity to check their observations, never miss an opportunity to do height, weight, blood pressure, etc. You can attend to the outstanding tasks that you've identified as a result of constructing the plan. It's an opportunity to provide health education to the patient, and it's also an opportunity to establish patient-centered goals and tasks. So then you'll have an opportunity to construct your team care arrangement if it's relevant and if the patient is eligible. You then obtain the consent from members of the care team that we spoke about before. You must document the consent using today's notes and using your written TCA consent if that's how you choose to do it. Offer copies of the information to the patient and the other providers. And there are, I'll just go back a step there are electronic platforms that have been introduced from time to time that do allow you to electronically share information to other providers. During the healthcare home trial, we used an information sharing platform. But for now, if you don't have that, go back to My Health Record. It's a valuable place to be sharing information and encourage your other providers to be able to access that. You need to develop and share your information. Most importantly, you're in charge of maintaining the coordination of this care plan. Often you're going to be the key person that everybody can communicate with. And it's also your job to follow up with the patient and the care team members. And over time, you establish a relationship with you tend to use certain physios and certain podiatrists, and you even get to know some of the other specialists, etc., that are involved in the care team. Now I'm going to talk about practice workflow, and there's numerous possibilities, and every single place that I've worked, I would have to say, is different. No two practices are the same. So I'm just going to introduce some ideas for you to go back to your own practice and think about how you can make it work in your practice. Talk to your GPs, talk to your practice manager, talk to each other and see what ideas that you can come up with. So this is just some of my ideas from from what I've done in places that I have worked and done care planning. So we start with the nurse identifying possible patients. I'm a fan of the appointment screen, so I've put the appointment screen in there. The nurse discusses care planning possibilities with the eligible patients, explaining the benefits and the review intervals, etc. And this may be from a phone call, or you may try and see the patient when they come in to see the GP, pop in and see them 5 minutes before their appointment, something like that. Again, think about how that will work for you. You obtain the patient consent, and in this particular scenario, you ask them if you could see them prior to their GP appointment. So you extend that appointment to include a little visit with you. You go about doing your homework before they come in, doing your file review and your data cleanse, and you start to construct your care plan. You can phone the patient if there's any missing important bits of information, or you can add those bits of information in when you see them. You have your appointment with them prior to them seeing the GP. They then have their GP appointment, and by that time, the GP's got this amazing care plan that you've put together that they can review and confirm with the patient. And then you rebook the patient for the 3-month interval. So you have your clinics already in place, and you start to establish a care planning list where you have a clinic side by side with a particular GP, and you may decide to start with one GP to champion your program, and then you roll it out to the other GPs. But ideally, the time that I have used previously is 20 or 30 minutes with the nurse, and then either 15 or 30 with the doctor, depending on how you work that out. And throughout the day, the patient sees the nurse, then the doctor, the nurse, then the doctor. This sort of system relies very much on the GP being on time. So initially, in those early stages, when this is a little bit not established, a little bit ad hoc, you don't have the same consistency in the appointments. But over time, as you bring your patients back in for their 3-monthly review, you will start to develop this structure between yourself and the GP. Workflow number 2, again, just coming up with an idea. You've got your patient identification. That can be them from themselves, from the nurse, or from the GP. The nurse preps the plan. So you do your data cleanse, your file review, you put together a care plan. The GP then sees the patient. The nurse in this particular scenario doesn't see the patient. Not ideal from my perspective, but some practices do choose to do it this way. The GP sees the patient, obtains consent, and confirms the plan. And the nurse and the admin team will assist with document sharing and provide a consent to participate if you've also done a team care arrangement. Scenario number 3, and again, there's numerous scenarios that you can put together. You have your patient identification, however that may be. The GP preps the plan. The GP conducts a consult and discusses the plan, and the nurse and admin assist with information sharing and sending the information, etc. Okay, so now we're going to talk about the care planning file check, and this is a really important step, and you need to do this before you even start to do the care plan. And particularly if you're using best practice and medical director, once you go into the care planning modules, you can't come in and out. You have to have all of this information done before. And when I first started doing care planning, I developed a little document that reminded me of all of the things that I needed to do before I actually opened up the care planning module and started to do the care plan. So this is what I would recommend that you do. First and foremost, you check previous billing, so you see what the patient's due for and what you can possibly bill. If you think that the patient may have gone to another practice and had a care plan, you can check that billing data through their My Health Record or PRODA. I always find if I'm in the patient record and I can open My Health Record, it's quick and easy to check rather than going to another platform, which is PRODA, to check their billing data. You need to consider their age and sex to establish what preventative health strategies you're going to put into their care plan, because remember, it's not just about their chronic disease, it's about good preventative health as well. So this is a bit of a cheat sheet for women greater than 50. You want them to have an FOBT every 2 years. You want to look and see if they're due for a mammogram, again, 2 yearly. Is their cervical screening up to date? Are their immunisations up to date? And consider all their other vaccinations of being up to date as well. So it's a good opportunity just to look at all those things. Men greater than 50, again, you want to look at FOBT, PSA, immunisation status, and consider what other vaccinations may be relevant for them. For both men and women older than 70, and again, this is in the resources that I provided to Jan and Fleur, so and Alini. So if you're wanting this, they can send it to you after the webinar. So for men greater than 70, you want to look at their comorbidities to see if they should have a bone mineral density even earlier than 70. But if, of course, after 70, we've just done a great bone mineral density drive at the Bronte practice, where the bone bus was only going to come originally for 1 day, and it's now been booked for 5 days, 5 solid days of our patients getting in the bus and having a bone mineral density scan. Amazing. Our nurse out at Bronte, Kate, put that together. It was just incredible. Have they had Prevnar 13? Remember, everybody over 70 needs a single dose of Prevnar 13. Have they had shingles vaccine? And in your practice, are you recommending Zostavax, the government-funded vaccine, or are your GPs looking at Shingrix? The other thing to consider are just some general tasks for everybody. Has the patient had bloods in the last 6 to 12 months? Have they had an ECG? I think it's a great thing to do an annual ECG. If you're coming from a place of a normal borderline ECG, if the patient wants to have something happen and something untoward, then you've got that normal baseline to go back to. Very important thing to do. Spirometry, we've sort of gotten away from doing spirometry or aerosol creating tests because of COVID. Remember, I certainly think about the need for spirometry with everybody who's continued to smoke past the age of 40, and should we be getting back to doing those for them? Is the person having vitamin B12 injections? Are they due for that? Are they due for their Prolia? Have we been doing their observations regularly, their weight, height, waist, BP, pulse, all those sorts of things? Are they up to date with their skin checks? And these are all things that you can do as the nurse when you open their file. Sounds like a whole lot of stuff, but once you get used to it, it's very quick and very easy to do. Now, just spend a little bit of time talking especially about diabetic patients. So as the nurses, you can be very valuable in completing the diabetic cycle of care, which occurs over a 12-month period. So it's a number of steps that we'd like to see happen for our patients who have diabetes to keep their care as optimal as possible. So someone who has diabetes should have annual bloods, including HbA1c, lipids, and glucose. They need to have an annual urine microalbumin. When I first started looking after patients with diabetes, we used to have to collect their urine for 24 hours. So we'd have these big bottles of urine, And then they changed it to 8 hours. Now you just need a spot urine. So there's no excuse for patients not having a urine microalbumin. They should have an annual podiatry review if they're low risk diabetics, more frequently if they're high risk. And the nurses can also check their feet at each visit. And I also recommend patients have a mirror and look at the bottom of their feet as well, because if they do have some diabetic neuropathy, they may not be aware of lesions on their feet. And for anybody that has looked after patients with high risk diabetes, their feet can become very damaged very quickly without them knowing, and it's quite catastrophic, losing toes and all sorts of things. You should be doing their observations at each visit, reviewing their exercise, their nutrition, smoking, alcohol, etc. each time you see them. And you also should be looking at their medication. And when all of those things are attended over a 12-month period, you can complete your diabetes annual cycle of care and bill the item number for that. And you can bill the diabetes annual cycle of care in combination with care planning item numbers. So it's good to get that happening again in your care planning structure. The other thing to check before you go about constructing your care plan is correspondence. So look at correspondence has the person seen a specialist? Are there any recommendations in your correspondence that you need to put in your care plan? And you need to add the providers into their care plan as well. So remember to include those. And obviously if the person has more than 2 providers involved in their care, then they can also have a team care arrangement. Also check the correspondence out. And this can be really valuable. Has the GP referred your patient to somebody and they haven't seen them? Have they been referred for something that's not been followed up? It's just a good opportunity to check all of that information. You can check with the patient. Have they seen the cardiologist? And then the cardiologist hasn't sent us any information back. We can then contact the cardiologist and get that information sharing happening and that information back into our patient file. And of course, we can add all of that information into our care plan. And then lastly, check the progress notes to see what the GP's written. Often there can be some very useful information there for your care plan. Finally, you get to construct your GP management plan and your team care arrangement. And as I said, it sounds like that's a horrendously large amount of stuff to do, but once you get used to doing it, you'll get very quick at it, and you'll absolutely realize the benefit of doing that. And I know GPs that I've worked with have said one of the single most important things is all of that data cleansing that the nurse does as a result of seeing patients for the purpose of care plans. It's really important. And the other thing that I wanted to say at this point before we talk about actually writing your care plan is that please don't think that the very first time you do a care plan that it has to be perfect. And I remember it was the second day I worked in general practice, a GP asked me to do a care plan, thinking, oh my goodness. And I spent hours doing this care plan. And what I've learned subsequent to that is that the first time around, it's going to be a good document and it's going to be very reasonable. It's going to be a good effort. But each time you see the patient, if you see the patients at regular intervals, each time you see it, you improve it. Each time you see the patient, you improve the data that you've got there for them. You improve the plan. And by the time you get to your 12-month period, if you've reviewed that care plan and or team care arrangement 3 to 4 times, at the end of that time, you've got a really good document for you to then do your new care plan for the next 12-month period. So please don't think it has to be perfect first time around. So now I'll talk just a little bit about care plan construction, and my job here tonight isn't to educate you with the software. but I will just touch on each, both best practice and medical director, because they're the two most common patient management softwares used in general practice. Now, for best practice, I'll talk about them first. Best practice has a very good care planning module down here in the enhanced primary care section. And I would highly recommend, if your practice uses best practice, to use that module to do your care plans. And the reason being that you can very quickly, very easily find what care plans have been done. You can cross-check it with billing data very, very easily. If you're using word processing templates and they're within the correspondence, it's just messy. And I would say that the document that you produce as a result of doing the care plan within the care planning module isn't as attractive as the document that you would produce if you were to use a word processing template, but you get used to it, and it is, you know, it is a reasonable working document that you can produce. So once you choose care planning in that module, it then asks you if you're doing a new care plan. If this is a new care plan and you've had one that you've developed previously, instead of typing it all in again, you can actually preload it with your existing data, and then you can go in and correct it. And once you do that, you get this section here, and you can see that this particular GP management plan is empty. And then I would start to build the problems from this. Will take, if I click on problem, it'll take me straight to the problem list within the patient file. And that's where, if you've got your data cleansed, that you're going to be able to just select from that list. And then when you go to goals, instead of inventing new goals every time you do a care plan, I would highly recommend loading into the back end of either best practice or medical director lists in alphabetical order of different conditions and what the goals and tasks related to that condition would generally be. And when I first started doing care planning, we used to use the Monash system, whereas now the RACGP have developed wonderful guidelines that we can utilise to develop those lists within the patient management software. I've tried talking to best practice about having them already in there. The custom ones that they provide are not that list. And I would definitely recommend doing a list. I've got a list in alphabetical order here. I don't know if you're able to see that, but my list is 10 pages long. And I will add all of that into the back end of best practice. So if, for example, I have a person with aortic valve disease, when I have the problem being aortic valve disease, pre-populated, because I've got it in my back end, will be that I want to maximize cardiac function and optimize their quality of life, that they need to take their cardiac medication, that they have their cardiac function monitored, plus or minus a surgical repair. So that gives me some information already that I don't have to make up just by choosing the problem aortic valve disease. So putting this information into your software saves you time, probably take you 2 to 3 hours to enter it all in, but definitely a very valuable thing to do. And any practices that I consult with to help you with care planning, I provide this information for. And it's not, I didn't make it all up myself. It's things that I've got from nurses that I've worked with, from doctors that I've worked with, and from RACGP guidelines of clinical care. So definitely a good thing to have. Sorry to go on too much about that, but it's definitely very valuable. So that's best practice. And once you build all of these things, when you go to print the document, it looks very different. It looks much more organized and something that you can utilize. Your team care arrangement will look very similar to this as well. and you can actually preload your team care arrangement from your GP management plan so that you don't have to do it twice. Now, this is medical director. I'm not as familiar with medical director, but I believe that that for the purpose of the care plan, you can update the list of the patient's current problems, similar to what you would do in best practice. You can create a needs list. And again, you can have that information preloaded. And sorry, I missed the first step. You go to this assessment module up the top to get these particular things pop up. And then you can build your list of tasks from that information. So very similar to best practice, but I believe that the document that is produced using medical director is not as it's not as nice as the document that you would develop using best practice. And the other way, which I'm sure nurses who have been around for any period of time would know, the word processing template for developing care plans. And often what GPs will do is they will put together a GP management plan which has a huge amount of problems and preventative items, and they will open that up, and for this particular patient they will just delete all the things that are not relevant. Another way of doing it, it's not as tidy and not as nice. It doesn't link in with your billing data. It's cumbersome to find because it sits in either correspondence in best practice or in your letter writing sections in medical director. So not as nice, but it is something that particularly our older GPs are used to using and like to use. So it may be that within your practice you accept a hybrid system as well. It's not, there's nothing terrible about doing it this way. It's just not as efficient and easy to use as using the care planning modules. Another thing that I just wanted to mention quickly is how do you get a buy-in from your patients? This is one idea that we came up with in the city, was we gave our patients that were enrolled in our coordinated care program a card that we called it a priority patient card, and we put their next appointment on there. And you can see that at the time our chronic disease management team were Jeannie and Kate, and the patient could call the practice and talk to either Jeannie or Kate on any given day if they had a problem. So if there was something that they needed or whatever, they could call their chronic disease management care team and they would help them facilitate that particular thing. And patients really like this. So it's something to think about in your practice, how you get that buy-in from the patients. Our last objective is to know what billing items can be claimed and what time periods we have for these. And this can be one of the trickiest things to get your head around. And you know, sometimes I feel like I walk around like I'm a Medicare encyclopedia, but it is really important to understand the item numbers and what can be billed with each thing. I don't, it's not my job to recommend things to you, but I will say that one tool that I've used in the past, that when I first started doing care planning, was a Business for Doctors, which is a GP who has developed a business which helps GPs manage the business side of their medical practice, and they produce both an electronic and a written version of billing items. And I find that really valuable because it's just like the whole MBS online put into a book, and it clearly tells you what you can and can't do. So can be quite valuable. I looked it up recently, might be about $150, but just one copy in the practice that the practice manager can use, and it's really helpful to do Medicare rejections, etc. as well. But let's have a look at these item numbers. So this is a chart that I've developed. Now there's a mistake on this chart, and a prize goes to the person who spots it. But I was disappointed with myself that I didn't spot it until just before we started the webinar tonight. But we'll see if any of you can identify it. So if we start at the beginning, if we look at item numbers that we can bill together, so we can bill by themselves or together an item 721 and 723. So on the same day, we can bill a GP management plan and a team care arrangement. We should try and check billing data in case the patient has had that care plan done somewhere else, but we should also annotate the service text. And this is where you can work with your practice manager and reception staff to make sure that these billings go through for you smoothly. And because you're billing more than one item number on the same day, you need to tick the box that says that they're unrelated, or you need to unrelate them in the service text. And if you haven't been used to doing Medicare billing before, that might sound like another language, but your practice manager will know exactly what I'm talking about here. With those item numbers, you can also add the nurse item number 10997, or if you're working for an Aboriginal Health Service, 10987. These can be done every 12 months. It's the minimum period unless something happens dramatically with the patient within that period of time. And can it be billed with a consult? No, no, and no. But it can be billed with a diabetes annual cycle of care, and it can be billed with a health assessment. So if you're a nurse and you're working with a GP and you're doing a health assessment and GP management plan and team care arrangement for your patient, your GP is getting very well remunerated for the care of that patient in that one appointment. So, and the patients like it because they don't have to come, back too frequently. So if the person is within the age group that makes them eligible for a health assessment, if you can try and couple it into the same time. And also you get really valuable information from doing your health assessment for your GP management plan and team care arrangement. So the next possible combination of item numbers I've got is a 732 with a 723. So what this is a review of your GP management plan, and you're adding in a new team care arrangement. And remember, before I said that can occur, say, along the way, your patient needs to see an allied health professional, or they get more providers involved in their care. You can then establish a team care arrangement. You do need to add text into your Medicare claiming, and you do need to unrelate those items from each other. And you can add your nurse participation item number into that claiming. Again, up to 5 times a year, you can bill the nurse item numbers. You can bill it 10 times for the Aboriginal health workers, but for registered nurses in primary care, not working with Aboriginal clients, you can only bill it 5 times. The rules for that are that you can bill a review every 3 months, a new GPMP and TCA every 12. And this is where the mistake is. Can it be billed with a consult? No, no, and no. Can't bill a consult with a care planning item number. And I have put the telehealth equivalent item numbers in there for you as well, but just keep an eye on those because, as we know, they change or have changed along the way. The next possible combination is a 721 and a 723. What that is a new care plan with review of a team care arrangement. And that can happen from time to time. Just say, for example, you had done the new TCA mid GP management plan cycle. The new TCA may not be due, but please, please, please try and get them happening hand in hand, and it just makes your claiming so much easier. Your new GPMP you can do every 12 months, every 3 months for the review. Can it be billed with a consult? No, no, and no, but can be billed with a diabetes cycle of care or a health assessment. And you can't bill diabetes cycle of care and a health assessment because you can't bill more than one time-based item with a GP management plan. But you'll get used to that. You'll get your head around that. Another possible combination is your review items, item 732, which you can bill individually or at the same time. And I would recommend having them at the same time. Medicare gets very confused if you bill them separately, and usually that requires a phone call to Medicare to sort out your billing by saying, oh yes, but last week I reviewed their GP management plan, but this week I'm reviewing their team care arrangement. Try and do it at the same time and you will solve a lot of your billing problems. How frequently can the review be done? Every 3 months. Always use service text, always unrelate the items from each other. Can it be billed with a consult? No, no, and no. Now, there are other follow-up nursing services, the 10987, which is the service by a nurse or Aboriginal health worker working with Aboriginal clients. You can actually bill this 10 times per calendar year, and it can be billed at the same time as your GP management plan and team care arrangement item numbers. The other nurse item number 10997, can it be billed with care planning item numbers? Yes. You must unrelate it to your other item numbers, and it can be billed 5 times in a calendar year. And I've got some little links there if you have issues with billing, multiple billing item numbers that you can go to get some information. But remember, co-claiming rules for GP management plans are that they cannot be billed at the same time as a consult. So the only things that can be added to your care planning item numbers are diabetes annual cycle of care and a health assessment, but not both at the same time. Okay, so that's the end of the things that I had planned to talk about in relation to GP management planning. I hope that wasn't too rushed, and I'm looking forward to some questions that are sitting there in the Q&A at the end now. But just before I do that, I'm just going to mention something on behalf of the Primary Health Network, and it's a project called Project Grow Training. And the purpose of this project is to educate GPs and primary care nurses and practice staff about the needs of people with intellectual disabilities. They also educate disability service providers as well, and the importance of preventative health and the importance of conducting health assessments for these individuals. And often these people have not grown up, they may not have grown up within a family environment, they may be in foster care, they may not know their family history, their carers may not know their family history, their carers may not know their medical history. So this project is really important at educating our primary care and disability service providers to work with people with an intellectual disability, to do really sound health assessments, get information. For example, their immunisation, because all of life immunisation recording has not been in that long, you may have no idea what immunisations this person had as a young person. You may need to do serology for that. And this education will help us in primary care for these patients in a much more optimal way. And what the Project Grow people are asking us to mention to you tonight is that this particular group of patients will also absolutely benefit from GP management planning and team care arrangements, because they need that structured care and how important that can be for them in reducing episodic care, for a start, reducing their admission to hospital, all of those things that we talked about before. And it's also an opportunity for you to get to know these patients better and be able to look after them in a much more useful way than what we may have done in the past. And I have actually worked in a clinic where we had a structured program for looking after our patients with intellectual disability, and particularly those that lived in group homes. And we used to bring them in on buses and have clinics where we did their health assessments and their care planning. And we did that routinely over periods of time. And it was so useful and helpful. So GROW training, it is called, and I can see that from my experience that this is a really valuable thing to do. So I'm very happy to mention it this evening. And that takes me to the end of my presentation. I hope that was useful, and I'll look forward to your questions now. Thank you.